For doing everything in time, mashallah, as always.
Our second speaker for this session is Dr. Naila Kayani. Professor Kayani is a medical graduate of Fatima Jinnah Medical University, Lahore. She did her residency training in USA and is board certified in anatomic and clinical pathology. She is a fellow of College of American Pathologists and Royal College of Pathologists, UK. Recently, she was appointed senior examiner in histopathology by Royal College. She is currently a dean of the Faculty of Histopathology at College of Physicians and Surgeons, Pakistan. Her special areas of interest in clinical care are breast and gynecological pathology, and other areas of interest are postgraduate medical education and quality improvement processes. She has held close to 30 national and international workshops and given 50 invited lectures in her area of interest. She has over 150 indexed publications to her credit. Professor Kayani, please.
Thank you, Dr. Sidra. I begin in the name of Allah, the most benevolent and merciful. So, can we have the first slide, please? So I will be talking about biomarkers in colorectal carcinomas, and this is something that is a lot of future to promise, and I'm so glad that Dr. Najib Nematullah has touched upon some of the themes that I will be talking about, like microsatellite instability, circulating DNA, and the gene profiling tests. So that gives me a good platform to reflect further on them. So some slides mere paas hai. I have to control. I have to make sure I press the right button. Yeah. So globally, this is the second common, the colorectal cancers are the second common malignancy, and third most in males and third most common in female. In the US also, it is the third most common malignancy. In Pakistan, as Dr. Najib Nematullah mentioned, there are many cancer registries, but there is a recent one that has been formed by a number of leading hospitals in Karachi along with NIH, Islamabad. And according to their data, it is the third more commonest malignancy in males and sixth most common in females. Predominantly, this is a disease that occurs sporadically, and some percentage is hereditary, which is about 10 syndrome, including the Lynch syndrome profile. What are biomarkers? These are substances that are present in our body, either as in a biological or a chemical form, that can be used as a markers to look at a characteristic of a tumor. They are currently, most of the used is being targeted towards development of personalized treatment, because the genomic profile of each tumor is considered to be unique to a given patient, and that the aim is to actually target that particular profile and manage the patient accordingly. They can be classified into diagnostic, prognostic, predictive, pharmacodynamic, etc., recurrence markers. But what is most important are the two categories, which is the prognostic biomarker or a predictive biomarker. So prognostic biomarker is something that tells you about the patient's overall cancer outcome, and I would give you the example of ER or estrogen receptors in breast, which is also a prognostic marker and also predictive. So how do you apply that knowledge? Well, if a patient is ER positive, is likely to do better than some of the other groups which are ER negative. Also, if patients, you give them to this group, you give them anti-estrogen therapy, so then they have a better outcome. So this is how that information is well established in breast. But at colon, we are in a struggle to develop something as robust as a ERPR. So how do these biomarker works? Very briefly, I will take you over this concepts of how these, there are three main mechanisms through which they work. One, and the larger group which is responsible for colonic carcinomas is the chromosomal instability group, which is also called CIN and responsible for about 85% or so. Then we have the microinstability group, which is MSI high, and it's about 15% or so. And then there is another, which is in which the cancer is promoted through methylation. And in addition to this, these mechanisms, there are other things that determine the prognosis in a patient, which include the TNM stage, the location, and the histological subtype. This is the characteristic, if you look at the upper half of the screen, the characteristic profile of developing colorectal carcinomas by a model that is well known, in which there is normal tissue, there is involvement of the genes, which are the tumor suppressor genes, and including including P53, APC, and other genes, and then they may go on to develop a tumor which is going to be, which may have microsatellite instability or may not have microsatellite instability, depending how the genetic profile or genomic profile evolves. So these are the two types that you can have, and then there is the third type, which is the tumor which will have the methylation defect. If the methylation defect involves the MSI, then it will be an MSI group, and if it involves the tumor suppressor gene, then it will be the MSI stable group. So the most common, as I said, is the CIN group, in which you have chromosomal instability, and this is manifested by loss of alteration in certain chromosomes or mutation, and the particular the tumor oncogenes that are involved are BRAF, KRAS, T53, and APC. At the end, and the pathways that are involved are PK and WTN. Why is it important to know? Because some of the drugs that we have now are actually acting on these pathways. KRAS is one of the most common culprits in this, and KRAS is involved in the division and in cell division, and it is a marker of poor survival and increased tumor aggressiveness as well as metastasis. And then also it may give us key to the presence of decreased response or resistance to certain drugs. So epidermal growth factor, as you can see on the cartoon on the right-hand side, can be seen on the surface. And then there are two pathways that lead through this, the Wnt and the MAPK pathway. And you can notice at the very periphery of the right-hand side of the slide, there is a heading saying RAS, which is KRAS, and underneath is RAF, which is BRF. And these are the pathways that are involved in further cell growth and division. So once these are affected, once these are triggered on, there is increased cell survival, there is a loss of apoptosis, angiogenesis, and metastasis can take place. So why is it important to know the pathways? Because they can, when you give a medicine, at times these pathways will block some of the EGRF activity, but will not affect the KRAS and the BRAF, and therefore it is important to know what is the status of these patients. So in microsatellite stability, this is something that happens during DNA replication, and because we have in our bodies MMR proteins, which are the mismatch repair proteins, they protect us from microsatellite instability. And this is a cartoon on the right-hand side showing you how various functions of this are performed. But once there is a defect in the mismatch repair system, we lead to unstable proteins, and these then proteins will lead to damage. So there is a group, there are 4 of them, MSI1 and PMS2, and MSH2 and MSH6. Now they occur in pairs. So MS1 and PMS3 is a pair, and the other one is MSH2 and MSH6. Now, if the MSH1 is affected, Usually there is loss of both, but if one and two are affected in a pair, then the other partner becomes non-functional. In our genomes, we have more than a million microsatellite instability checkpoints. But there are 5 that have been picked up by NIH, Bethesda, Maryland, USA, to be tested, to be used as a test. So these are some of the methods in which MSI can be checked. And what I want to point out that the gold standard is, of course, PCR, but what is routinely available across Pakistan in many leading laboratories is through the immunohistochemical stains. And that's a very reliable method, and you can see the reliability is as high as 95%. And I would encourage you to use that service because that's readily available, and it is not very expensive. Then we have the third system through which tumor can occur, and that's the methylation pattern. And this methylation pattern can either affect the tumor suppressor genes or the MSH1 system. So this is methylation and occurs through the cysteine, guanine, phosphate islands that are present in our genomic profile. This is just to quickly show you that most of the tumors occur through a mechanism involving the KRAS, and a minority is through MSI. But where it is, the highest areas involved are the cecum, rectum, and part of the ascending colon. This is some of the clinical and biomarkers that are actually, this is what is currently known to or is advised to use, and that's microstability, MSI profile, the KRAS or the NRAS and BRAF mutation. This is what is required that should be tested in a given patient. And you can see why it is important because, let me see if the pointer works on this side of the screen, because you can, what is happening, what is new in terms of MSI is the fact that you can use now PD-L1 and PD-1 immunotherapy in these patients, and there's strong data now to use this in this group. So that's a great ray of hope that has emerged recently. I won't go through this detail, but it's just there to show you what else is being there, and ctDNA, as Dr. Najibullah mentioned, then and how you can use targeted therapy in that regard. Similarly, there are some for some others, but mostly you see when there are a lot of red checks, and that when those red checks are present, it tells you that the treatment won't be beneficial. So there's a lot happening in terms of trials and what is new emerging, data that is emerging, but this is yet to be proven in clinical. These are some of the gene signatures for colorectal carcinomas. These kits, they look at various genes in a larger form, 18, 16, whatever, but none of them is yet FDA approved. So this is still work in progress, but with a great promise. I just want to, being a histopathologist, wanted to flash you that there are many other things which are helpful in histopathology, and it is not only the genomics that are going to lead us in this. So genomics actually adds upon the histological knowledge that we have. So that will still be there, and then this will be additional information. So many things like lymphovascular invasion, tumor infiltrating lymphocytes, and microvascular density, and many others which I have not directly reading through, will help us determine the future of this profile. So this is a guideline as to what to do in patients who have metastatic disease versus non-metastatic disease. And then this is just a summary of what I've said, the 3 types and how do you manage these various types. There's this, the CIN group, which is the chromosomal instability, the MSH group, and then the methylation group. And this is what is suggested to be used in this form. So when you have a patient who has, you should do molecular screening. Molecular screening is now available in the form of NGS, at least in our institution. I know it is expensive, but it is worth it. you are after all trying to save a human life or have a better quality of life. So you can either do molecular studies for prognosis, or you can have biomarkers for predictive, or you can exclude Lynch syndrome, etc. Then liquid biopsy, which is actually the circulating DNA, can be used, and this is something which still has to prove its worth, but very much on the horizon. So in conclusion, I would like to say that mutational testing of specific genes for EGFR is been well known to have as a targeted treatment. Mutations in some have prognostic value like BRAF, KRAS, and NRAS. And BRAF has associated with poor outcomes, and MMR protein dysfunction or deviation is very helpful, because now we have a chance to treat this group with immunotherapy. So thank you for your attention.
Thank you, Dr. Naila. Now